Hello, everybody. Happy New Year.
Aloha.
Yay. Hey, Juanette. Good to hear from you.
How are you?
Good. I recognize your voice from anywhere.
I don't know, is that good or bad?
It's good.
Oh,
A good, cheerful, energetic voice.
well, I'm glad. Thank you.
Oh, Sylvia Osak is joining us.
Well, we will get started. Welcome Hawaii, welcome Oahu and neighbor islands, and also to our friends in the US Pacific Islands like Palau, who is joining us on this call. We're so happy to present this CME activity jointly provided by the Queens Medical Center and UA-JABSM Department of Geriatric Medicine. My name is Rita Bell Fernandez. I'm an associate professor with the Department of Geriatric Medicine and will be the course director for the ECHO series for care home and foster homes. And I thank Dr. Ida Nguyen for her leadership and her vision, who has developed this ECHO over the years and using the 4 M's and has got us to this amazing place and time. And I thank her for trusting me and turning the baton over to me. So I'm very happy to be the course director of the ECHO series. Just a reminder, please enter the name and credentials of everyone viewing the geriatric ECHO for CME attendance purposes. You could put this in the chat. As a reminder, evaluations are required for CME, and we will provide the link in the chat, and you will all get certificates for attending today's session. A little bit about ECHO. I want to remind everyone this is an ECHO webinar, and it's different from grand rounds, it's different from lectures, it's different from workshops and meetings that you may have attended before. So what is ECHO? It means that this session serves as a forum for mutual teaching and learning from experts and from each other on the front lines. The ECHO motto is all teach, all learn. So it takes a village. It takes all of you to create this community of learning. And I thank you for joining us for this series and for your participation. A little bit about our format. After a short lecture from the experts, we will share expertise from the rest of the team and open up for case discussions. We invite you to share any geriatric topic. It may be the topic of today, or it may not be the topic of today. It doesn't matter. Our interdisciplinary team is here as well, and we're all willing to teach and share from our collective wisdom with you. We have Dr. Ida Nguyen, Juanette Gaylord, Maribel Tan, Juliana Caldwell, and Lila Ventar, who is part of the interdisciplinary team. We only ask that you keep it HIPAA compliant for case discussions. So we do not need to know the name of the patient, the age, gender, where they're residing. We can keep all that anonymous and still discuss the case. I'm so excited that last year we finished the 4-month series on mobility, and we learned from physical therapists, speech therapists, occupational therapists. If any of you are interested in viewing these past lectures, you can find them on our website. Now, sadly, we cannot offer certificates of attendance for videos you have viewed. We can only offer for live attendance and live participation. Now, in 2023, we are on a new 4-month series, and this is the next M, M for medication. So
John,
we are
forward
starting.
the slides. Sorry, John, can you forward the slides? Okay, wait, next one. Okay. Sorry.
All right. We are starting with talking about managing anxiety and depression. And please join us for next month. We will have a lecture on managing insomnia, which is difficulty sleeping. Now I have the pleasure and honor of introducing our most wonderful speaker. We are starting 2023 with a big bang. And we have Dr. Ida Nguyen, who is going to present to us. She is an associate professor with the Department of Geriatric Medicine, John A. Burns School of Medicine at the University of Hawaii. She is program director of the Geriatric Medicine Fellowship Program, and that has lots of responsibility taking care of all of the fellows and residents and medical students. She is a geriatrician that works for the Queen's Health Systems and serves as the medical director at a nursing facility. She is also the founder and current vice president of the Hawaii Medical Directors Association. She is board certified in geriatrics and palliative care. She is also a consultant for Aloha Care Health Plan in Division of Long-Term Services and Support. She is currently the principal investigator for the GWEP grant. This is directly from the federal government, from HRSA, and it is a very prestigious grant that we have in Hawaii, training all of the workforce into the field of aging and geriatrics. Through her role in several educational grants, she has developed a wide network of collaborators, partners, community stakeholders, and caregivers who care for our elderly population. And bottom line, she is a strong advocate for improving geriatrics and dementia care, striving to help patients and providers help seniors age as gracefully and as beautifully as possible. So please join me in welcoming Dr. Ida Nguyen. We are so happy to start this year off with you, Dr. Nguyen. Thank you so much for your presentation.
Oh my goodness, that was a very, very generous introduction. I'm embarrassed a little bit. Okay. All right, we'll start off by a little COVID updates. We're not done with it yet, unfortunately. Next slide. So I don't know if you remember, right? We started off in December of 2019 with the original COVID, right? And then as the months rolled along, we had Alpha, and then we had the Delta variant. And then last year we got the Omicron variant. And unfortunately, the Omicron variant went off and splintered and created many Omicron subvariants, including several that are just spinning around in China right now, and we don't even know anything about them. But here in the United States and many other parts of the world, we have the Omicron subvariants, which themselves, they actually like merged together and recombined. And now we have this Omicron XBB spreading around the US and becoming dominant at this time. And unfortunately, as each new variant adapted, it's been able to spread even more easily than its ancestors. And the incubation periods are just getting shorter and shorter. And so kind of as it evolves, we're just kind of getting more infective. Next slide. So that's the bad news, right? It's highly contagious. And unfortunately, it escapes all the previous antibodies that we worked so hard for our bodies to make, right? And so previous COVID infections or vaccinations won't fully protect you from getting another COVID infection. And then treatments with the antibody drugs like Evusheld and Bebtelovimab might not help either. So that's kind of the bad news, however. Next slide. So as you see, we had this vaccine, right? The original COVID vaccine that we made initially. when Omicron came around, everybody put all their efforts in and created a new vaccine for the Omicron variant, right? And this one is the bivalent COVID vaccine. It has both components of the original and the Omicron particles so that it attacks us. So unfortunately, right, as we know, the Omicron evolved again to subvariants and then subvariant, the Omicron XBB. So it does have some remnants that it remembers a little bit what Omicron looks like. And so there is some protection against that. Next slide. So how do we protect ourselves? What's the best way? Is to get the bivalent booster, because there is still some memory of those antibodies. Not very strong, not a whole lot, but something is better than nothing. And so if you get the bivalent booster, you can help protect our kupuna. And we also have to, if our kupuna gets sick, we need to treat as soon as possible. Unfortunately, not with the antibody treatments, but with the antiviral medications. And the ones that are right now working are Paxlovid or remdesivir. So there's still stuff we can do. So let's not give up. And of course, masking still prevents all COVID and all other respiratory illnesses as well. So let's not forget to do that, even though we're sick and tired of it. So that's all I have about Omicron and COVID and XBB. Any quick questions on that? Okay. All right, on we go. We're going to do the medication safety. We're going to talk about medication safety. So, all right, are older adults taking too many medications? I think all of you would be like, yeah, I think so, right? Older adults are taking many medications. Why? Because they have many medical problems, right? And the problem with medications is that all medications have side effects. There's no such thing as a free ride. Every medicine has side effects. And the more medications you're taking, the more side effects you might have, and the more drug interactions there might be. And as we all know, the more medications you take, the more patients hate taking them, right? They're hard to swallow sometimes, and sometimes they're challenging to take them all correctly. They all have different instructions. Some of them take them 3 times a day, others twice a day, others before meals, others without food on an empty stomach. Everything is hard to keep track. And so it makes it very, very challenging. Next slide. And another problem is that in older adults, as we get older, it takes longer for all of these medications to wash out of the body, right? Because the kidneys are getting older too, and the liver is getting older, and they don't work as effectively. They work, still working, but they're not quite as speedy as they were before. And so drugs don't leave so quickly, they accumulate, right? And if drugs accumulate, they have an increased risk for side effects such as falls, confusion, dehydration, low blood sugar, bleeding, you name it, right? That's what we have to be looking out for, especially the ones that can cause a lot of big problems. Next slide. Okay, so the American Geriatric Society developed this list of medications that are dangerous and may be inappropriate for use in older patients. And these are known as the quote unquote Beers criteria from Dr. Beers, Mark Beers. And so he created this list of dangerous medications. And in this medication safety series that we're going to be having over the next 4 months, our goal is to make you aware of these high-risk medications so that you can help us monitor safety and to work together with the doctors to reduce their use. They don't have to be taking all of them, right? We can see what we can do to reduce their use and help make it safer. So what are some of these medications? Well, the ones that we are especially concerned about and the ones that we're going to be talking about over the next few months are the mind altering drugs, the ones that affect the brain, right? The things such as depression and anxiety directly impact the brain, right? And that's what we'll talk about today. Next month, we'll talk about sleep, right? And then the following month, agitation, and then pain as well. Next slide. Okay, we'll start off with a case scenario. I'm sure you guys know somebody like this, right? This is an 87-year-old woman who's constantly complaining. She says her daughter never visits or calls. She actually calls once a week. She can't sit still, and she always calls for staff several times a day to help her. She tells them all about her aches and pains, the problems with her eyes, her trouble breathing, her tummy ache, and that she needs to see the doctor. She's always asking about when she has to take her next medication. And all the doctor evaluations have been fine, and they tell her it's just her nerves and that she should continue to take her diazepam, her Valium, as needed when it is very bad. Actually, she's been taking it for a long time, for many years already, occasionally. However, she is asking for it more and more frequently now. So what should you do? Should you give her the medication? Right? That's the easy solution, right? That's the easy thing to do. Oh, you want a pill? Take a pill, and then she'll sleep the rest of the afternoon, no problem, right? That's not what we're after. Okay, so next slide. So we're going to talk about maybe a strategy to figure out what to do. So first, how do we know it's anxiety, right? Well, this is just questions from the general anxiety disorder, the GAD, 7 items, the GAD-7, that, if they have any of these problems and how often these problems occur, such as feeling nervous or anxious, can't stop worrying, or worrying too much about different things, having trouble relaxing, or being so restless and pacing and rummaging. It's hard to sit still, becoming easily annoyed and irritable, and feeling afraid that something awful might happen. Next slide. Next slide. Yeah. So one way, as I said, to treat anxiety is with benzos, right? This is a class of drugs called benzodiazepines, and a lot of doctors call them benzos, or you can see them as BZD, and that's just the short-term terminology in case you hear it. It comes in 2 forms, right? The short-acting and the long-acting and medium-acting. Acting ones are like the diazepam, which is Valium. I'm sure you've heard of that, and Klonopin. Or the ones that are long-acting, they actually stay in your system for days, especially in the elderly. It can be you take 1 dose, and that dose is going to be in your body for like at least 5 days, to wash out. So those are particularly dangerous. Then there's short-acting benzodiazepines, right? And those are the ones, lorazepam or Ativan, you might hear, temazepam, which is Restoril, or alprazolam, which is Xanax. So these are the common ones. Next slide. So the problem with benzos, the number 1 problem is they're addictive. And once you start taking them, they're hard to get off, right? You kind of always want more, right? The other problem is drowsiness and forgetfulness and accidents. Actually, it alters the mind, similar to being drunk. And so accidents that occur are similar to those with drunk driving. And these accidents include things like falls and hip fractures, right? And it's worse when combined with opioids or narcotic pain medications or alcohol. So even if you think you're just taking a small amount along with your benzo, you take a little sip of it, a little drink, a little wine with dinner, that kind of multiplies, and bam, right? You have that accident or that fall or hip fracture. Or you go to sleep and you don't wake up for 18 hours or something like that. So benzos have a lot of risks. Next slide. This is a slide showing that depression and anxiety often go together. Do you see in this picture, they're teammates and they come and they bully you together and you're on the opposing team. So how do we treat this combination? Antidepressants also, fortunately, also help anxiety. You don't have to use the benzodiazepines, right? You can use antidepressants. And so antidepressants are the first line treatment. And it treats depression, and it's also helpful for anxiety. Next slide. This slide should be familiar to you. If you've attended my previous sessions on depression, you'll recognize these flavors of ice cream, right? There are many classes of antidepressants, and individualized selection is based on diagnosis, patient characteristics, and their side effect profile. And to help the doctor choose which antidepressants to use, you have to let them know about the patterns you're seeing with regards to their sleep, their appetite, or anxiety. Those are the main ones. And so if you have a depressed resident who has trouble sleeping at night, the doctor might choose the trazodone, right? Or if they have poor appetite and insomnia, you might choose the mirtazapine, right? Or if they have a lot more anxiety, you might choose citalopram or bupropion or one of those. So it really helps when you share your observations. Next slide. Right. And of course, all antidepressants have side effects as well, right? So we have to monitor closely. Side effects include things like being sleepy, confused, more depression, being anxious, agitated, restless, or dizzy. And so we have to monitor. Once they start these antidepressants, you have to monitor for side effects within 1 or 2 weeks. Be on the lookout for these things, and then you call the doctor if you start seeing problems in these areas, and then get them to reduce the dose or change the medicine or something like that. But really, the point here is that all antidepressants also have side effects. So your main approach should be non-medication care. Next slide. So anyway, so here is cognitive. So cognitive behavioral therapy is very helpful for anxiety. And what I'm doing here, I bolded, and I underline the word behavioral, right? Because in people with dementia, right, the cognitive part doesn't work too well, right? That this is the brain working. So really interventions on their behavior is the main thing to focus on. So that includes things like reassurance, which I know you're very good at, right? Helping them relax, imagery, and deep breathing techniques. I wanted to show you this Calm app. I don't know if any of you've seen it. It's kind of neat. So I'm going to have John go ahead and show this and try to follow along as it breathes in and breathes out. Oh, it's being weird right now. It's glitching. Anyway, if you do it on your own, it might cooperate a little bit better here. But let's go back to the slides, John. Sorry. But this is free and it's very simple, and it sort of guides you, and you could just sit there and you can do some deep breathing for, 10 or 20 or something like that. And that can just really help settle things down. Actually, if on the Calm app, there is also, there's different ones. This one's just a plain blue background circle thing. They have ones with, the river and the mountains or the stars and the sky. And so they have imagery as part of this deep breathing to go with it. And they have different, I think others, motion as well, like stretching. Okay, next slide. Okay, and a part of this behavioral therapy also includes exercise. Exercise is very good for anxiety. So, maybe you need to just take a break and go for a walk every day. And if they can't walk, you take the wheelchair and you go outside, right? And you change the scenery and you go relax. There's also something called Tai Chi for seniors. And this is actually from JABSOM, the John A. Burns School of Medicine. We actually have, I have a link in there that you can go to later on. We can put that into the chat box later. You can take a look at that. And you can see that there is a woman who's seated in a chair. So you can do Tai Chi in a chair. You can follow along while this guy's doing it standing up for people with different abilities. And of course, Tai Chi also goes with some deep breathing. There's chair yoga as well. And you can actually, if you click on the chair or the senior button, right, you can see more of these poses and these stretches that are all based on in a seated position on a chair if you need to. But maybe trying to do this every morning for your residents might be a good way to start the day. Next slide. And, it's been shown that food has a very big impact. Your diet has a big impact on anxiety and depression as well. And so generally to avoid sugary foods and drink, no alcohol, no caffeine, and just include more protein, omega-3, fatty acids, which is why salmon is in here, right? And the avocado and the whole grain toast, right? So fruits, vegetables, carbs, more complex carbs and protein are generally better than having snacks like ice cream and cookies. Next slide. And of course, to avoid triggers for anxiety. Sometimes after you've lived a lot of life by the time you're 80, 89, right? And sometimes you've accumulated some trauma and some things have been very hard to live through. And so we should be mindful of that some of our residents had lived through some very difficult times, and be aware of that, whether it's physical or emotional trauma. And remember that those traumas can trigger anxiety. So if you know that, they went through some tornado at some point and it's raining outside, it just might trigger something, right? Or if there's, the news, when the news comes on, it starts talking about wars or something like that, time to turn off the TV, right? So avoid those triggers for anxiety, avoid overstimulation, and avoid understimulation. Next slide. And this should be familiar to you from our past as well, but it's always good to remember. We can remember about grapes, right? And this is behavioral activation. So this stands for G for gentle, being gentle to yourself. R, relaxation. Accomplishment is A, accomplish one thing. Pleasure is listen to some good music or taste a sweet fruit, pet an animal, do something pleasurable. Exercise, take a walk or stretch, do some Tai Chi or yoga, or breathe, and talk to a friend. Try to reach out and make a connection to somebody. Next slide. And then, think about creating an anxiety and depression care plan, not just a depression care plan that we talked about in the past. This one, we're going to add anxiety to it. So evaluate them for depression and anxiety. We're not going to be asking you to do the GAD-7, but you can certainly do it on your own if you like, and it can be very helpful. But then plan interventions for when these occur. If you know they have anxiety, let's see, when this hits them, what are we going to step in and do right away, right? And then also plan ways to prevent these from happening. So if that means that every morning we do, Tai Chi, right? And in the afternoon, after lunch, we do deep breathing. These are just ways that you could just be part of your routine. And then try to reduce the risk of those high-risk medications after implementing all of these non-drug strategies. See if your plan is working, and then evaluate it again and see after 1 month, after 2 months, are we using less of the benzodiazepines? Or even using less antidepressants if that's, if they're really doing super well with all of these non-drug treatments. That's the idea. Next slide. So now we're going to come full circle and it's going to be your turn. And I'm going to be eagerly awaiting to see what you kind of come up with. So this is the same lady, right? She remembers she's complaining. She says her daughter never visits or calls. She's restless. She calls out for help. She talks about her aches and pains and eyes and breathing and tummy aches. She wants to see the doctor. She's insisting on seeing the doctors, and she's always talking about her next medication. She's obsessed with it. So what do you do now? What would you do? I want some very creative people here to share. Okay, feel free to speak up or use the chat box. Have you had anyone like this?
If she's on routine, you can put it on like a board and just notate when her next medication is going to be so that she is aware of when her routines are.
Mm-hmm. Yes, that's a good idea. Right. She probably forgot. Right. What else? I know you guys have this similar patients. And you just told me that you don't want to give her more Valium, even though she's asking for it. Oh, talk to the doctor on the times okay for the patient to call for spontaneous calls to the daughter. Okay. What else would you do? Having the daughter call a little bit more frequently? Does it need to be a long call? No, right? Just a short call sometimes will do. Any other ideas? What are you going to do when she tells you that her eyes hurt and she needs to see the doctor? Anyone? Are you guys going to call the doctor? Oh, eye exercises. Okay. And maybe, okay, with the doctor, maybe you can just do saline drops, right? Keep those eyes nice and moist. And then maybe you can do exercises. Yeah. And maybe you can include the stretching and the neck exercises to go with that, right? That way she feels like she's doing something. And deep breathing and relaxing with that. That's good.
I offer snacks as a distraction.
Yeah, I do that too. It works. Right. So distraction, right? Get them off the subject. Take them outside for a walk, right? So that's what you might do immediately. What might you? Any other ideas? Do you notice that sometimes when these guys start going, right, it makes the other residents crazy? Right? Everybody, it kind of rubs off, right? And then all of a sudden everybody wants help and everybody is needy. Right? So maybe, yeah, maybe a group deep breathing exercise, right? Or a group stretching. Just build it into your day. And probably the staff will need some stretching too after a while and deep breathing. And then creating those activity. Remember that activity calendar, right? Sometimes if they have something to keep them busy, right? Continuous activity programming as opposed to just sitting around and just thinking about the pain in your knee. Right. If she has aches and pains, maybe Tylenol. And what if happens if she has complaining about trouble breathing? What would you do?
Take her O2 and
Yeah.
show her.
That's right. Maybe just go and listen to her lungs and take her oxygen and count her breaths and say, you know what, your lungs sound good, but I think maybe we can do some deep breathing. That will help, stretch out those lungs a little bit. That's probably all it needs, right? And then you can start on that. Yeah, eye exercise. Yeah, listening to her lungs, right? What happens if she wants to see the doctor? What are you going to tell her?
I'll go ahead and take care of calling the doctor and setting up your appointment for you.
Or you can let them know that, yes, you have one next month already, and we're going to write everything down, right? And let them know to take care of that later. Okay. All right. So does anybody have any similar patients or cases like this that you are particularly challenged with? Do you have one right now? If you want, you can just type it into the chat to, I don't know, maybe Rita Bell. And then she could just read it out and it would be anonymous if that would be more comfortable. Okay. Anyway, you can talk about it, think about it, and bring it up anytime you like. I'm gonna pass this back to Dr. Fernandez, because and she'll talk a little bit about de-stressing.
Thank you, Dr. Wen, for an excellent presentation. I love the breathing, the cognitive behavioral therapy, and all these non-pharmacological strategies that you shared with us today. Because often we only think of these medicines and we forget about all these other strategies that can be used to manage anxiety. Thank you for a very enlightening presentation. And I appreciate us learning all these things from you. We're going to move on to talk about wellness. And I want to wish us, let's go back to the previous slide, John. They are going to be on Let's Talk Story for another 10 minutes or so. I want to wish everybody a very happy Chinese Lunar New Year, Tet New Year, happy Year of the Rabbit, happy 2023 with much happiness and prosperity and good health to all of you and your clients. Anyone would like to share what they are going to do for their wellness this year? Maybe you made a New Year resolution that you would like to share with us. Something we could learn from you. If you've joined a new class, a new program, you learned something new that you're going to adopt in 2023. We would love to hear from you. On my end, I am making an effort at wellness to eat better. I'm trying to make a conscious effort to increase my vegetables and good quality proteins, lean proteins at every meal. That is something that I'm hoping to add to my wellness and to give myself more time to sleep. So sleep is a big thing, and we're going to talk about insomnia next month. But that is a focus of mine, to make adequate time for sleep and make it a priority. We would love to hear from you. This is a time you could unmute yourself. You could get on video if you like. We'd love to see you. It's very lonely out here in a Zoom world.
I noticed that Renata said something in the chat about a case, the opposite scenario, with the family visits too often. And it's probably causing anxiety on your, they're probably anxious, not the patient, right? And it's making you all worked up as well. So we're going to have to do something with them. Oh, what do we do when families are a little bit too intrusive? Can we set limits on them? Sometimes we forget, huh?
Renata, would you like to share with, we don't have to talk about the patient's name, age, or any descriptors, but just in general, if you want to give us the gist of this case, because others might have the similar issue that you are facing.
Oh, I don't know where Renata went. Oh, she's still there. Yeah.
I will share with everyone about a particular case that I encountered. I've done a lot of home visits in Kalihi Valley and seen patients in care homes and foster homes when I worked at Kokua, Kalihi Valley. And a case that comes to mind is, I had she was about 78 or 80-year-old Japanese lady who had anxiety. And we need to remember, like the case Dr. Wen gave us, people who are anxious do not tell you, I am anxious. An anxious person doesn't tell you they are anxious. What does an anxious person tell you? They have stomach problem, they got chest pain, they got palpitation. It comes up in these kind of symptoms. And sadly, people with anxiety, they get over-tested. They go to the ER so many times and they put through numerous tests that they don't need to go through. But sadly, that tends to happen for anxiety. So in my particular case, this patient would always complain of, heart is bumpy, bumpy. She would say, doctor, my heart is going bumpy, 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 bumpy. And as a result, this was triggering an emergency room visit. And they would send her home, discharge her home on Xanax, on alprazolam. And we would discuss, alprazolam is just as needed medicine. The main underlying medicine, as Dr. Wen's talk said, the #1 treatment of choice is often an antidepressant that can also treat anxiety. So the class of medication that treats anxiety, that is an everyday medicine, is the SSRI, like Lexapro, Celexa, Zoloft, Paxil, Prozac. Those drugs help anxiety, and they're an everyday medicine. And if persons take it every day, then you will see a reduction in these ER visits and hospital visits. And it took some time to achieve that in my particular patient, the Japanese lady, because she only wanted to take Xanax. she wanted the benzo. She didn't want to take the other medicine that was the everyday medicine. And it took a lot of education that we need to have this everyday medicine, so you feel calmer, you feel less anxious, and these episodes of palpitations and chest pain and all that would not arise. And slowly we saw this change over time. And I bring up a very similar analogy is with asthma. You know, in asthma, there's two kinds of medicines. There is the everyday medicine or the maintenance medicine for asthma, and there is the emergency, the immediate relief. So in asthma, you have the albuterol that is a rapid, fast-acting medicine. But asthma patients often have to take a everyday medicine like Advair, or they may take Symbicort, or they may take another inhaler, a steroid inhaler. So in the same way in anxiety, we need to remember that even though these benzodiazepines like Xanax or alprazolam or lorazepam or Ativan, they are only like a temporary relief. They are not to be every day and forever. So this is one, we have care home operators and foster home operators on this call. Remember that these drugs are not every day forever. And I'll tell you about another care home, a different care home, where every time I would visit, the care home operator would say, please refill the Klonopin. And I would say, but it's getting better now. We will make it less, or we'll make it as needed. And then they would tell me, no, please don't do that. If you do that, we're going to have so much problem. Patient will not sleep. We're going to be awake all night. So they would beg me, please, doctor, please refill the Klonopin. And it took really several months for me to build trust and titrate down, because before I wanted, if the patient was getting better and stable, we wanted to move this from routine every night to PRN every night. So that was the first step, to move it from routine to as needed. So let's remember that these drugs are not the safest in the elderly. And if the patient does better and is stable, we always need to decrease the dose of these benzodiazepine drugs. Any questions on this? I know we have care home operators and foster home operators. Do you have any stories to share? This is Let's Talk Story Time.
Oh, how to address sexual dysfunction with SSRIs in male patients who are still sexually active. There might be other antidepressants we could use. And maybe they don't need to be on an SSRI. We could try others, which is why it's so important to review side effects. If we don't know about it, we can't change the medicine.
Thank you, Dr. Wen, for your recommendation. Another thing that I have tried for sexual hypersexuality or sexual dysfunction is sometimes an antipsychotic might work in a low dose and just like a temporary situation. Sometimes it is also situational. It may be to one particular person or one particular caregiver. So you could change the caregiver, if possible, to a different, say if the company was sending a particular caregiver, you could ask the company, can we have a different CNA or a different aide to work with the patient? That may help also. But thank you for bringing that up. We appreciate questions and feedback. This is a learning environment, and we welcome all questions, all comments, all suggestions. Anyone worked with their case managers on these medicines? Did the case manager try to decrease them or stop them? Anything you would like to share about your case management agency and what they did with the benzodiazepine drugs? moving forward in this year, we are going to invite the case management agencies. We are going to invite the foster home case managers and care home case managers so they can also participate in this ECHO series, because I know they do a lot with the medication management, and often they're the ones that look at the medicine very thoroughly and they reconcile the medications. So we would love to have them on this series, and we're going to extend an invitation to all of them. So maybe next month we will have far more participants, and we can have the case managers present for us any cases. There's a question here. There are protocols on how to safely wean off benzodiazepines. Yes, thank you. Thank you, Renata. Yes, you don't just, especially for patients who've been on it for several years, you cannot just stop it. They have to be titrated down, decreased in dose, and slowly weaned off, especially for people who took it for years and years. Thank you, Renata. That's a very good point. Would you like to say something on this, Renata? Okay, we will move on. We appreciate all of the comments in the chat. John, let's go to the next slide. So starting this month, we would appreciate if you could share with our team some of these things on medication, because we're looking at medicines very closely, and we want you to look at the chart, the patient's chart. I know you have a paper chart. Look at the chart and the med list and see if you have any of these high-risk medications. And we've given you examples. So examples of benzodiazepines are lorazepam, clonazepam, Xanax, Ativan, Klonopin. These are all benzodiazepines. Opioids, you all know what that is. Anticholinergic medications are like Benadryl. Also look at, are they on sedative and sleep medicine, like Ambien? And we're going to talk about this more next month. Ambien, Sonata. That's another high-risk medication in the elderly. See if they're on any muscle relaxant. So if they're on any of this, you just make a check box. You can check the box at the side. Are they on any antidepressants, any antipsychotics? Antipsychotics are like your risperidone, your Haldol, Seroquel. Look if they're on any mood stabilizers, Abilify, Depakote, lithium, and check the box or you can ask your case manager to help you when they evaluate the client's chart and look at the care plan. See if they're on any of these medicines. And then how often you look at this. Is it once on admission? If they went to the ER or hospital, then you got to do the med reconciliation when they discharge. So you can check the box how often you do it. And then what's the next step? Did the case manager ask to refill the medicine, renew the medicine, stop the medicine, decrease the medicine, or just monitor it? And last column is who reviews the medicine? Whether it may be the PCP, maybe you are in the wonderful Queen's Home Geriatric Program and they come to your home. So nice. And they review the medicine. So you could check, maybe it's the APRN or the physician. So let's check who does this. And we would love for you to share this with us every month, like you've been sharing before on other outcomes. Please continue to do this because we would like to see what is going on with the medication. It's one of the 4 M's as part of healthy aging in our community. Any questions on this sheet on what you have to check? Any questions on these check boxes? Is the questions easy? Are they confusing? Do you need more clarification?
Feel free to type it in if you want.
Okay, it seems to be very clear. All right, let's move on to the next slide, John. And if you could please put in the chat the evaluation link. We want you to know that evaluations are emailed out using an automatic system. So please double check the spelling of your name and email address. We want to make sure you are given credit for attending this 1 hour with us. And we want to make sure you get your certificate of attendance.
Hey, John, do we have a link? Or no, it'll get emailed out, right? Okay. Oh, there is a link. Okay. Click the link, everybody.
We would love to have your feedback on how we can improve this series. So do let us know about our presentation and other suggestions you have for future presentations. We're happy to incorporate new ideas and make our series even more better.
Yeah. We really appreciate your joining. And yeah, if you have your friends, remind them that our series has restarted. So we'd love to have more people join us next month.
And thank you, Dr. Wen. You gave us so much education, knowledge, wisdom, and sharing all of these breathing apps and non-pharmacological tips. And I'll remember grapes. Now I'm leaving today, I'll think of grapes. Thank you so much. A great presentation.